What's going on, all of my healthcare brothers and sisters? I hope you are having a wonderful day. We are going to start to pivot on this channel and we're going to look more closely at the critical care profession. If you've chosen the critical care profession, congratulations. Whether you are a novice nurse or a seasoned nurse looking for a change, ultimately this series is going to be for you. Today we're going to be looking at what can you expect inside the ICU? What's happening? What am I walking into? Is the ICU really for me? Let's get started on kind of what the ICU is and what you can expect. So what exactly is the intensive care unit? The intensive care unit is a specialized hospital unit that provides care for patients that have life-threatening medical conditions. These patients require close monitoring and often need life support machines such as ventilators, as well as major drips like vasopressors, vasodilators, whatever the case may be, to help them breathe and maintain their hemodynamics. So the ICU team is made up of a specialized team of nurses, doctors, and other healthcare professionals that work together to provide the best possible care for these critical care patients. ICU units tend to be smaller than other units inside the hospital, which allows for more of an intimate environment and it allows for the team to get to know their patients and their families better. So really the huge difference that you're going to see, especially when you're comparing it to something like the medical surgical unit, is with medical surgical, you may have an abundance of patients that you're caring for at one time, right? Maybe 5, 6, 7, 8, depending on where you work. Whereas in the ICU, you could have anywhere from 1 to 3 patients that are all critically ill. Just because you have less patients doesn't mean that it is less intense in regards to the patient load that you would see in the medical surgical unit, meaning that those 3 patients can feel like 8 patients on med surg. So I think that's the number one thing that's kind of eye-opening or kind of like a culture shock when people come to the intensive care unit is they're like, I can't believe how much you're running around and you're doing things. That is because the intensive care really takes a lot out of you. Just like those 8 patients on med surg are going to take a lot out of you, those 1 to 3 patients can be equally as tiring as they would on a different unit. So what can you expect as a new intensive care nurse? As a new intensive care nurse, you can expect that you're going to be challenged, both physically as well as emotionally. You're going to be caring for patients who are very sick and often are very close to dying. This can be difficult to deal with on a day-to-day basis, but it's important to remember that you are ultimately making a difference in these patients' lives. You can also expect that you're going to be working very long hours. The ICU is a 24-hour operation, like most units, so that 12 hours is even longer depending on the patient's conditions, especially during shift change. Sometimes during shift change, your patients can code and you have to stay behind to help stabilize those patients. So sometimes that 12 hours becomes a little bit longer than you had expected it to be. However, you're also going to be dealing with a lot of autonomy as well as in the ICU. You are going to be making those clinical decisions about your patient's regular care, and you will be working collaboratively with other members of the ICU team. That is a great thing about ICU is that no one is above anybody else. You are not better than the doctor is not better than you, you're not better than the environmental care team. My environmental care team caught a lot of issues that I didn't necessarily see because I was focusing on all my patients. We all work collaboratively and we are all a team. You will also be able to assess your patient's condition quickly. You have to have that skill of critical thinking and critical judgment in order to make critical decisions when you're looking at the patient's condition. You really need to be able to get an accurate assessment and develop a plan of care accordingly. You're also going to have to manage multiple tasks simultaneously and maintain a calm demeanor while being in this fast-paced environment. The most important thing that you can do as an intensive care nurse is to advocate for your patients. I think that's the number one thing that we do as nurses is advocating. If you feel that something is wrong, you have to say something is wrong because unfortunately your patient can't, right? You are going to be their voice when they are unable to speak for themselves. And you will be the one to make sure that they receive that best possible care and those best possible outcomes. You're also going to have to be really comfortable with technology because in the ICU, that's all we use, right? Pretty much anywhere in the hospital. The ICU has very specialized life support equipment that you're going to be able to use to monitor for vital signs. You're going to have to input data into the computer. You're also going to have to troubleshoot a lot of the different modules, life support devices while you're taking care of your patient. Trust me, there's going to be a lot of technology that you need to know. The best way to prepare for the career in ICU, if you don't feel that you're a strong nurse clinically yet, is to get experience in a different specialty. Now, one of the things that I always say to nurses, especially nurses that went through the pandemic in nursing school and didn't get a whole lot of clinical experience, that want to be in the ICU but don't feel very comfortable critically, it really is dependent on where you feel like you're at when you enter the hospital system. If you really don't have that foundations, if you never worked in healthcare before and you're really having a hard time, medical surgical might be the unit for you to start on. I know that that is controversial right now because everybody says you don't need to start on med surg to go to ICU. That's correct. You don't have to start on med surg to go to ICU. However, having that foundational knowledge and that ability to, take care of patients with just the foundations that you would see on medical surgical units. Of course, you have to critically think. Of course, you have to use clinical judgment, but that's where you start building it, right? You start building it on that unit so that you can be successful in the ICU. But if you feel like you've got the foundations, but you're just not quite ready to go all the way up to ICU, you can always enter PCU. That's another critical care unit. They see critical care patients all the time. They don't necessarily need life-saving support. However, that's still a great place for you to build up on your critical knowledge and your critical judgment. Once you feel comfortable in those positions and you've got a few years under your belt, then I would say apply for ICU. If you don't feel like you're strong already clinically. If you feel like you're strong clinically, absolutely go straight for ICU. But take that time, if you need that time to grow within your profession, and use it as an ability to see different things. Maybe you go someplace else and maybe ICU was originally your dream and now you want to be an ER nurse, right? Maybe you're like, you know what? I want to do emergency medicine. That's completely up to you. That is what healthcare does. It gives you the ability to do so many different things. It's ultimately challenging as well as rewarding. So take the time, really assess where you're at, and make the best decision for you. So let's talk about how the intensive care is different in regards to how you deliver patient care. Within the intensive care, you're going to be doing total patient care. That means that you're going to be caring for both the physical, emotional, and spiritual needs of your patients, but also their families. You're also going to be providing all of the care that is needed without the help of a certified nursing assistant or other aides that you would typically see on other units. So, the helping patients to the restroom, cleaning them up after bowel movements, sometimes certified nursing assistants can get vital signs. There's really a big scope of practice that certified nursing assistants do, but within the intensive care unit, you lose that because you are the primary nurse and you really have to rely on your teammates to help you care for your patients. You're going to be bathing, toileting, obtaining labs, vital signs, etc. All of that is going to be on your own. You're also going to have fewer patients, but I want to say you're going to have more responsibility. In the ICU, there's typically fewer patients than you would see in other units. However, each patient requires more intensive nursing care. This means that you're going to be ultimately responsible for each patient. And it's important to understand that while you have the motivation to become an ICU nurse because there are fewer patients, it doesn't mean that your workload is going to be any less. I think we talked about that before. It's really important for you to understand. Those 1 to 3 patients can feel like 8 on the medical surgical unit. That workload can sometimes be very immense. What I will say is that what makes ICU so different and why people find it such a rewarding experience and career is because you're often challenged with different kind of severities of illnesses and the need for nursing interventions. You really truly build yourself up as a nurse, as well as how you think and how you respond to different situations because of the ICU experience. ICU really truly sets you up to work anywhere in the hospital because of that critical thinking that you build within that unit. So now let's talk about what kind of patients you're going to see within the ICU. The ICU patient population is really diverse depending on where you work. You can see patients of all ages, newborns if you work in the NICU, all the way up to elderly patients depending on your specialty. You will also likely care for patients with a wide range of medical conditions, especially if you work in a general medical ICU. You can see patients such as like people who are having heart attacks to even organ transplants if you work on like a transplant ICU. There's no one size fits all approach to nursing, especially when it comes to ICU. There's really truly an abundance of specialties. My personal experience is I was a cardiovascular ICU nurse. So all of the fresh op patients that had cabbages, valve replacements, TAVRs, everything you can think of in regards to the heart came to me. And that's where I got a lot of my experience. That's the specialty that I chose. That might not be for you. Maybe you want trauma ICU. Maybe you want to see the people that have bones sticking out and maybe burns. Maybe you're into the burns patients that have completely covered. That's a very specialized and really requires very strong nurses to work in a burn unit. But there is no one size fits all. You can work anywhere. One of the most important things that you can do as an ICU nurse, your most important goal is to learn as much as you can about the conditions that your patients are going to be experiencing. This will allow you to provide the best possible care for your patients and will also help you understand the challenges that your patients are dealing with. No matter what your specialty is, you can expect to see a wide range of patients during your time in the ICU. One of the best pieces of advice for new nurses that are entering the ICU is to be a sponge and soak up all of the information that the seasoned nurses are going to give you. If you go into the ICU and you keep saying, I know, I don't need to hear this again, you're not going to get the best experience. In your preceptorship, you are ultimately in the driver's seat of your education. So even if you know something, it's okay to say, I have an idea about it, but can you explain it to me more? That motivates your preceptors to want to mentor you and take you under their wing and show you everything there is in the ICU. You ultimately are in the driver's seat, and it's really how you approach it in regards to if you're going to get a lot out of your preceptorship or if you're not. So let's talk about things that you're going to need to know. What skills are you going to have to possess in order to be successful in the ICU? You are going to need to know a wide range of skills. These skills are needed in order to recognize patient deterioration, prevent negative outcomes, as well as be successful and effective in the ICU. Some of the skills you're going to have to possess is the ability to think critically and act quickly. There is always going to be something that is going to pop up that you're going to have to fix immediately. You're not going to have a whole lot of time to look something up initially, especially if a patient is deteriorating really quickly. You have to have the ability to manage multiple tasks simultaneously. We talked about it before. Those 1 to 3 patients can feel like 8 in the medical surgical unit, and you're going to be multitasking constantly, simultaneously from patient to patient and patient. So you really have to have the ability to be able to multitask and remember things that you've done previously with a different patient, especially when it comes to charting later, right? You also have to have the ability to work well under pressure. Patients crash all the time. Sometimes patients we just know are not going to do well, and those are the patients we keep a closer eye on. And then there's sometimes a patient that's doing really, really good, and then all of a sudden they crash. So you really have to have a calm demeanor, especially when everything is kind of going awry within the ICU, and work really well under pressure. The ability to work independently or in a team. So you are absolutely going to be working independently when it comes to caring for your patients. However, because we talked about before, you're not having a whole lot of that aid support that you would typically have in other nursing units, you really have to rely on your team. So when you know, say you're having to prone a patient, proning a patient requires a lot of people. That's your patients that are usually on neuroblockades. And especially in COVID, we saw it a lot with COVID where we were turning patients constantly to help get their lungs to expand and oxygenate. That piece of turning a patient that's ventilated from their back onto their stomach is very, very difficult. It requires RT. It requires several nurses, sometimes maybe even the doctors involved, depending on how hemodynamically unstable these patients are. So really, you have to work well independently as well as with your team. Excellent communication skills. It's incredibly important to have excellent communication skills. You are going to be talking to doctors, dietitians, nurse practitioners, PAs, your colleagues, specialists such as like cardiologists, pulmonary. You're going to be talking to physical therapy, occupational therapy, speech therapy. There's so many different people that you are going to be conversing with, as well as the patient's family. So it's really, truly important that you're able to communicate appropriately to all the parties that are involved in a patient's care. What I will also say is that if there is something you are not understanding, say you're having a conversation with a physician and the physician's rattling some stuff off and you're like, I didn't catch any of that. Don't say okay or say yes when they ask if you got it. Say, can you please repeat that? Or you repeat it and say, I just want to clarify what you just said, blah, 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 blah. That way it helps build a rapport with the physicians, and it also builds trust, right? It builds trust within the team. So that way you know that they know that you got the information and that you know that they understood that you had the information. Big, big, big key tip when it comes to working in the ICU. Strong assessment skills. So it's widely said that nurses never use their stethoscope after nursing school, right? Sometimes in certain units, you might not necessarily use your stethoscope. Guess what? In the ICU, you got to use your stethoscope. There's just so many things that are happening with the patients hemodynamically. They're very critically ill. You have to use your stethoscope because one of the big things that I see a lot in the ICU is fluid overload, right? These patients aren't moving. We're not able to get them up out of the bed in the chair all the time. They're just kind of laying on their back. We shuffle them, back and forth a couple times, but it's still not as good as if the patient was walking and moving and sitting up in a chair. So ultimately, listening for crackles, especially in those lung bases with our patients that are unable to ambulate and do the things that they would typically do, is critical. Because if we don't catch it early enough, it can lead to much more severe consequences later on down the road. So yes, you have to have strong assessment skills in the ICU. You also have to understand different medications' effects, how they affect each other, including patients that are on multiple high-risk drips. Patients are going to be on so many different kinds of drips that necessarily don't converse well with each other. We already know the basic things about we can't mix certain medications that can't be mixed together. However, sometimes patients are going to be on multiple drugs, one working on one part of the body, one working on the other part of the body, that might not work well with each other and cause an inverse effect, not a good effect. It could actually cause something bad. So it's really, truly important to know those high-risk medications and why we wouldn't give certain medications with other medications. We're going to go into that later on in different videos that I do throughout this series, but I just wanted you to be aware that that is also a possibility when it comes to medications. And then lastly, superior time management and organization. We talked about how it feels like some days are just going to be erratic and there is nothing you're going to be able to do to get caught up, right? It just happens sometimes in the ICU. So really, you have to have those superior time management skills and organization to make sure that one, your patients are getting the best care, and two, you can get out on time by making sure you're documenting all of the things that you did that day, and you can walk out feeling that you've made a difference and that everything is done and you're not at home sleeping, hearing the call lights go off or thinking about, oh, did I chart that? That's the stuff that I'm talking about, that time management and organization. So if you feel like you have these skills or if you feel like you can develop these skills, then a career in ICU is most likely for you. So let's begin by talking about shift expectations. What does a typical shift look like? I want to caveat this by saying every shift is going to be completely different. But some of these things you're going to see every single shift regardless of what happens during the shift. So one of the biggest challenges that new nurses in the ICU is learning is how to manage their time. With so many patients requiring constant care, it can be difficult to know where to start and how to prioritize your day. So one of the things that helps you with that is huddle prior to the start of your shift. Not everybody does it, but the teams that do are usually successful with it. Depending on your hospital's shift start time, you may be required to come in about 15 to 30 minutes before your typical shift would begin. During Safety Huddle, the charge nurse is going to discuss changes that are happening on the unit since your last shift. Any new patients, maybe there's any kind of like big patient safety concerns that are happening on the unit. There may be additional information such as like education that's due, hospital initiatives will also be discussed during that time. But this will also be a time that you can ask questions and voice any concerns that you may have about your shift. It's really important to pay close attention to the safety concerns on the unit during huddles because as an ICU team, as you will learn, we really look out for each other and look out for our own. We don't let people drown unless we're drowning ourselves, but we tend to always step in when there needs to be a point in time where we have to step in, and that's why safety huddles are so important because then we can know this patient's really not doing well. We all need to keep a closer eye on this patient, okay? So that's the big advantage of having a huddle before your shift if your hospital provides you one. So at the safety huddle, you typically have a report or care planning meeting, okay? You'll receive a report from the nurse who is leaving their shift. During report, you want to receive an overview of what the patient's current condition is, what their vital signs are, any medications that they're receiving, as well as any recent changes. You will need to assess each patient and develop a plan of care after you receive report. The number one tip I'm going to give you is please do not be assessing your patients as you're receiving report. That's really truly a time for you and your offgoing nurse to have a discussion about what's happening. This will allow you time to prioritize what your patients are going to need based on the resources that are available. You're also going to be responsible for updating the patient's medical records and care plans throughout the shift. So as the patient's condition changes, ultimately, so does their needs. So as we talked about before, you're going to have amazing assessment skills in the ICU. You're going to be able to need to assess different things with your patients. Vital signs, reviews of systems, that means all of their organ systems. Mental status, huge, right? Our patients usually experience some kind of confusion, even delirium within the ICU. Any treatment-specific assessments such as train of 4 for anybody who is on some kind of neural blockade. What does their proning schedule look like? How often do I need to flip them on their back, their tummy, and their sides? And then ventilator management. Depending on the ICU you go to, some have respiratory therapists that solely manage the vent, while others have respiratory therapists that work in conjunction with nursing, so they both manage the vent. So it's really dependent on the ICU that you go to. All medications and drips. Make sure, big tip, never let your medications run dry. That basically means don't let the bag ever become empty, right? You always want to have another bag of whatever drip they're going to be on, especially if you know they're going to be on it for a while, at the bedside ready to go in case something were to happen. You also want to just start discussing other treatment options if drips are getting close to maxing out and they don't seem to be working. If you're on a vasopressor and the blood pressure still isn't getting up there where it needs to be based on protocols, then that is the time to start discussing with the physician, maybe this isn't the best. Maybe we need to add something else. Maybe we need to take this away and use something different. You really need to start having those critical discussions when you're seeing that medications aren't working. And you want to adjust the titration of drips related to the relevant assessment data, right? Whatever the data is in regards to your blood pressure or your oxygenation, whatever it is that you're basing your critical decisions, medications, and treatments off of, you really truly want to make sure that you're using that data to make the best decisions for your patients. In addition to these assessments, you're also going to monitor intake and output. Huge in the ICU, right? We want to make sure whatever we're putting in, we're getting out. We don't want them to be net positive, meaning that more has gone in than come out, or negative sometimes, where we've given them some in, but we've getting way more out. What's happening with the patient, right? We want them to be neutral. We want them to get what we put in and get what we get out. Urinary output, if there's a catheter in place, right? We want to make sure that we're assessing that. Fecal output, if there's a flexi-seal, that's a tube that goes into the patient's anus that collects any kind of diarrhea that helps with wound healing and things along that line. drainage from any wounds, or tubes such as wound vacs or chest tubes. We really want to make sure we're paying very close attention to that, right? If we have a patient that just came out of surgery and had a chest tube in, and it's only been an hour and they put out 900 mLs, where is all that blood coming from, right? What's happening with my patient? They might have to go back to the OR, and that's when you're going to be calling the surgeon and letting them know something's wrong. We want to look at the results of lab work as well as diagnostic tests. That's huge, right? We need to see, does our patient have any electrolyte abnormalities? Are their kidneys working appropriately? Comparing results to the patient's baseline. So that's huge within ICU. You want to look and see, what was the patient's baseline? Are they improving or are they worsening based on that baseline? If you can know specifically where they need to be or where they started, it can give you an idea if treatment is working or not working. Care planning. That includes things like multidisciplinary rounds, talking about restraints, medications, and procedures. What is the plan of care going to look like for that patient that day? And then lastly, you're going to need to provide comprehensive education when it comes to both your patients and your family. Emotional support is huge. What I will tell you is, don't be the only person providing emotional support. If you feel like you need additional resources because there are end-of-life decisions being made, we're talking about maybe withdrawing life support for a patient, involve your chaplains, right? Your chaplains are going to be huge when it comes to helping you with the emotional side, as well as helping families grieve and deal with those hard decisions that patients and families are dealing with. Close monitoring. You're going to be monitoring everything, as well as constant reassessment of the patient's condition. So let's talk all things medication administration. You're going to be doing this every single shift. It's going to be something that you're going to need to know, right? Your patients are very sick. They're often going to require multiple different kinds of medications to help stabilize and improve their condition. So as a nurse, it's really truly important that you become familiar with the many different kinds of medications and what they do. What is their mechanism of action, right? What do they work on? What's the indication? Why would we give this to our patients? What's the contraindication? Why wouldn't we want to give it to our patients? Is there any side effects that we need to know, that we need to be looking for as the patient's nurse? And then how do these medications interact with other medications, right? If they don't interact well, we might not want to give those two medications at the same time, as well as nursing implications. What am I going to do as a nurse while taking care of a patient receiving this medication? It's also good to know the different kind of ways that we can administer medication, because there's so many different kinds of routes. There could be IV push. You could give IV infusion, subcutaneous, intramuscular. It could be topical, maybe even rectal or oral. That's just to name a few of the different ways that we can give medications. It's also good to know, maybe we can't crush this medication. Maybe this medication has to stay whole. We can't give this medication to the patient because they're not able to swallow their pills. So do we need to get a different kind of medication? Can I not give this medication with a certain kind of juice or certain kind of solution? Those are all things that you want to know when you're administering meds. Some of the most common meds that you're going to see in the ICU are pain medications. Patients could be on PCA pumps, or it could be you going in there every hour to deliver morphine to the patient, maybe even more frequently, depending on if the patient's in palliative care or end of life. Sedatives, right? Sedatives is huge. We usually have sedatives on board when we have patients that are on a mechanical ventilator, because we don't want them fighting the pump, and we want them to be calm and relaxed so that the vent can do what it needs to do to help the patient improve. Anti-anxiety medication. I don't know about you, but half the time I need anti-anxiety medication, especially working in the ICU, because there's just so many things that are happening. And especially when it's happening to that person, they might need to have anti-anxiety medication on board to help them kind of relax and calm their mind. Neuromuscular blockades and paralytics are huge, right? Sometimes we have to paralyze our patient in order to provide treatment, such as our patients that developed COVID during the pandemic. A lot of them, a secondary cause of COVID was the acute respiratory distress syndrome. They developed it with complications of COVID. And what we were finding is that they were having severe ARDS, is what we call it, acute respiratory distress syndrome. They're having severe ARDS, so we were having to paralyze patients in order to make them more comfortable with the vent so that they weren't fighting the vent, as well as help us with proning. So because they're not able to move, get up, ambulate, sit in a chair like they would typically do, we were on a schedule, right? We had to move them from front to back to side every single day while they were on these medications. So that was huge. Antibiotics. We want to be stewards of our antibiotics that we're providing to patients, meaning that we want to make sure that they are receiving the correct antibiotics for what they are specifically treating, as well as the shortest period of time. Because as we know, we do end up developing some kind of multi-drug, resistant organism. And that is usually caused by antibiotics because they were on it for a long time. And now there's mutations of what we were treating that are no longer responding to the antibiotics that we were giving. Cardiac medications, huge, right? I was a cardiac nurse. I know my cardiac medications. But yeah, your nitro or your vasopressors or whatever it is that's working within the cardiovascular system, huge. Diuretics, going to be another big thing. If you have patients that are maybe in the trauma ICU that are receiving multiple blood transfusions, you want to make sure that you have diuretics on board, right? Because we're introducing a lot of volume to a patient, and sometimes that can build up in their lungs. And if it builds up in their lungs, it doesn't matter how much blood we're giving them. Now we've got an issue with their breathing, right? So really making sure if we've got those massive amounts of blood transfusions that we're doing with these patients, making sure we have some kind of diuretic on board. And then idotropes and vasopressors. Again, very important to know, especially when you're caring for your ICU patients. So IV starts are a common task in the ICU. You're going to have to know how to properly insert an IV, start the IV infusion, and monitor the IV site for any complications of infiltration or other complications. You will be consistently starting IVs to prevent infections as well. So every so many days, depending on your facility, they're going to make you take out the old IV and start a new IV so that way that site doesn't get contaminated with any kind of infections, because as we know, critically ill patients are more prone to developing infections because, again, they're not able to move and their body's not able to respond appropriately. And lastly, you need to know how to manage multiple lines, not commonly seen in lower acuities such as central lines, arterial lines, and femoral lines. As you know, these are lines you don't typically see. For patients or people that are considering going into the ICU, specifically cardiovascular ICU, you're going to see a lot of femoral lines, especially patients coming out from the cath lab, or maybe who even had open heart surgery or something done, depending on where they were able to get access. What you will find is that when you pull that line out, the patient is going to bleed profusely, right? Because that femoral area where that artery is that they inserted it, or the vein, depending on what they were doing, wherever they inserted it at, it's going to bleed profusely. So you're going to have to hold pressure in that area for like a minimum of 20 minutes to make sure they don't develop any kind of hematoma or something after the fact, right? So it's really, truly important to know how to manage these kinds of lines, especially when it comes to your critically ill patients. And lastly, with these lines, it's really also important to know what kind of medications can go into these lines. With an arterial line, you're never putting in any kind of medication into those arterial lines that you find sitting in your patient's wrists or their forearm right here. You never, ever, ever, ever want to put medications in these, right? You never want to put any medications in any kind of arterial line at the end of the day. So knowing what the lines do, knowing what they're for, and what you can't do with them is ultimately going to be the best thing for you to figure out when you're new to the ICU. So let's talk multidisciplinary rounds. Everybody that gets involved in multidisciplinary rounds, especially when you're new, are usually a little freaked out by it because it happens so quickly and there's just so much information that's taking place during those rounds that it can be a little overwhelming. So hopefully this helps give you kind of a general overview of what it is to help relieve some of that anxiety when it comes to talking during these rounds. So in the ICU, you're going to be part of a larger team that's going to consist of your intensivists, respiratory therapists, physical therapists, occupational therapists, speech therapists, social workers, case management, dietitians, as well as chaplains. That's just to name a few people that could be involved. You will ultimately participate in these daily rounds with the team to discuss what the patient's progress is, What are their goals? And are there any changes that need to be made to the care plan? Because you are ultimately visually seeing that patient for 12 hours during that shift, whereas everybody else sees them for a much shorter period. It's important to be an active participant during rounds and to voice any concerns or questions that you might have. As nurses, we have eyes on the patients constantly, so we are ultimately the people that provide the most up-to-date information to the team. In order to be an advocate, we need to know our patients front and back when it comes to working with them in the ICU. This is also the time to ask for orders or maybe some kind of assistance that you're going to need later on, such as restraints, drip titrations, patient movement for procedures. If you have a patient that needs to go down for an MRI and they're on a mechanical ventilator, that's going to require some more people, right? What I will tell you also, so that you know, is that there is no transportation when it comes to the ICU. You are the transportation. So you go with your patient wherever they go, right? They're critically ill. They have to have the nurse with them at all times. So if they're going for a procedure, but they're attached to equipment and you're going to need additional people, that is the time to ask for it. After rounds, it's ultimately you are going to be the person responsible for carrying out what that plan of care looks like, ensuring that the patient has what they need in order to recover in the ICU. So reassessments as well as activity of daily living. It's really important that you know that you're going to be performing some kind of reassessment on your patient at least every hour minimally. There might be more frequent assessments, such as like blood transfusions. You're doing it every 15 minutes or every 30 minutes, so on and so forth. But you're going to at least be in that room every hour doing some kind of reassessment of your patient. That can include checking your patient's vital signs. What is their current level of consciousness? What's their respiratory status? How are their wounds looking? Are they getting really nasty and we need to change them? Do we need a new wound vac? Whatever that might look like. As well as your IV sites. What does your IV sites look like? Have they infiltrated, or are you going to have to do something else with that IV, remove it and put in another one someplace else? So like I said, reassessments typically occur anywhere from 15 minutes to every hour, depending on your patient and what's going on. Additional things in regards to your assessments also include those activities of daily living. So that's, do they need a bed bath? Mouth care. Are we needing to turn and reposition them so we can get them off of their backs? Changing the patient's dressing, providing ambulation assistance. Some ICU patients, even on vents, can ambulate in some ICUs. It's a huge thing that's happening. They're finding more and more positive patient outcomes with patients that are able to ambulate even while they're on the ventilator. And also, if they have any kind of like Foley catheter or Flexi Seal, do we need to provide any kind of catheter care, right? You ultimately are going to be performing a lot of comfort measures when it comes to your ICU patients. So that way it'll hopefully help them in the long run in regards to their total recovery within the ICU. So documentation. I'm going to be very honest with you. We're probably spend more time documenting than actually providing care to our patients because there's just so much that has to be documented. It's really, truly important, though, that you document information correctly and accurately in the ICU. You're going to need to be able to document all of your assessments, medications, treatments, titrations, ADLs, whatever it is. Any kind of patient interaction that you have has to be documented in that electronic medical record. There's also a chance that you need to refer back to your documentation if your patient or patient family decides to sue the hospital for their care and you are subpoenaed. That is why it's so important that you document accurately and effectively when it comes to your documentation, because there is always a time that you might be deposed, meaning that you have to go speak on behalf of the care that you provided to a patient. If the families decide, even like 7 years down the line, it might not be somebody immediately. It could be a family that just decided to do this much later, because depending on where you live, the statute of limitations in regards to the time limit that they can sue you is a little bit different. But it could be 7 years later, and all of a sudden now you're being subpoenaed for the care that you provided, and you have to refer back to your documentation in order to provide a picture of what that patient care looked like. As nurses, we're ultimately held accountable for our documentation. It's really important that we are accurate and as thorough as possible. In the event of a patient safety event, your documentation is going to be used to help determine what happened and what changes need to occur in order to prevent any kind of safety event from happening in the future as well. So sometimes there's a special dance that we have to do in ICU for any kind of diagnostic testing or procedures that need to be done. The ICU is full of both of these. Many times patients are admitted to the ICU for specific procedures or a set of diagnostic tests, and that can be everything from bronchoscopies, cardiac catheterizations, CT scans, MRIs, PET scans, labs. It could be a multitude of things. As a nurse, you really truly need to be aware of when the test and procedure is going to be scheduled so that you can coordinate with other disciplines to get the patient to the procedure safely. Now, what I will tell you is sometimes procedures are done at bedside. Depending on how critically ill or hemodynamically unstable the patient is, a lot of times some of these procedures can be done at bedside, and they are, while others can't. Sometimes patients have to be opened up for some reason and they need to go to the OR. So you have to be able to know where the procedure is taking place, what you're going to need for the procedure, or what resources you're going to need to move the patient for the procedure. If it happens that you have a patient on a ventilator, like we talked about before, you're going to have to coordinate with your department's respiratory therapy team as well as transport team to help you get the patient down there safely. Because as we know, a lot of times these patients can't go in wheelchairs, right? They're going to have to go in their beds, and we're going to have to wheel them down the hallway to get them to their procedure safely with the help of our coworkers and our colleagues. It's really, really important to understand what the dance looks like in regards to getting patients to where they need to go with multiple disciplines within the ICU. One of the most important things that you're going to do as an ICU nurse is provide emotional support to patients and their families. Patients are incredibly sick, and their families are going to be extremely worried about them. If your family member was in the hospital, you'd be worried too, right? If they were having some kind of critical condition taking place. Ultimately, as nurses, we need to provide emotional support for both the patients as well as the family. This can be extremely difficult when you're caring for multiple patients and families at the exact same time that might be going through different barriers or different life-changing decisions all at the same time. As nurses, we need to have the ability to compartmentalize our emotions and provide support in a way that is both professional as well as compassionate. You can't be at the bedside bawling, right? You can't be crying harder than the family's crying when they're making these tough decisions. We have to be strong, but also compassionate for our patients and our families. It is also best to get healthcare partners involved. If you have any kind of chaplain or spiritual care involved at your facility, get them involved. They are experts in dealing with difficult situations as well as coping mechanisms, going through grief, different kinds of processes that families are going to be dealing with as a loved one is making final decisions, or, the physician states that the prognosis isn't good and most likely the patient might not leave the hospital. So really, you have to be very strong internally because you're going to ultimately be having those conversations with your patients and their families. What I will always say is that the ICU is very difficult emotionally a lot on nurses. And while chaplains and spiritual care leaders are there to help the patients, they're also there to help you. So if you're ever feeling, that your day is just not going the way that it needed to, and now you have a patient that's making end of life decisions and you're feeling emotionally overwhelmed and you just need sometimes to let it out, use your resources. I've had many conversations with my chaplains as well as our spiritual care leaders about how I felt, and it's okay. The chaplains speak to each other, they speak to other people. You can't internalize everything and not process it in a healthy way, I guess would be where I'm going with it. So if you are experiencing those feelings, just know that it's normal. It's not everybody's experience. It's not just you. It's extremely normal in the ICU, and it's just everybody copes and deals with it in a different way. So whether that is you needing to go out and exercise to let off some steam or getting therapy. I absolutely love therapy. I had therapy for a very long time during the COVID pandemic because of all of the effects that it had on my mentality. It's okay to see a therapist as a nurse. It's okay to reach out to your chaplain, your spiritual care leaders to have those discussions. What I will say is just don't internalize it to the point where you just melt down and you just don't know how to handle it. If you're recognizing that it is becoming a little bit too much for you, then that is when the time to speak to your leaders and say, hey, I think I need some support. There's amazing programs, employee assistant programs, therapy, whatever it is that you need in order to cope with the emotional experience of the ICU, please, please, please reach out to those people or those groups or whatever it looks like, so that way you can handle what you are also internally going through appropriately, as well as healthy in regards to your mindset and your mentality. And lastly, we're going to talk about how to deal with high stress in the ICU environment. The ICU can be a very high stress environment. You will need to find ways to deal with the stress in order to provide the best patient care that you possibly can, as well as take care of your own emotional and well-being. There are many different ways to deal with stress, and it's really dependent on what you find works for you. You could do yoga, meditation, maybe you can talk to your friend and family. Sometimes it's difficult to talk to friends and families because they really don't understand what it is that we do as healthcare providers. But if you have somebody who is empathetic towards you and just tries to at least listen to you, I think that can be absolutely incredible when it comes to dealing with stress. Maybe you need to listen to music. Maybe therapy is something that you need to enroll yourself in, and maybe just some kind of other exercise, whether it's running, hiking, whatever the case may be, whatever you find helps you. It's important to get out of the house and reset your mental health in any way that works for you when you need to. Sometimes just stepping away from patient care to have a moment to yourself to center yourself and remember why you became a nurse also helps. Just let your leadership know, let your charge nurse know, I just need to step away for like 10 minutes and just kind of reset yourself. Work with your team, work with your charge nurse, work with your leadership when you need to have that time to yourself so that you can reset yourself mentally and grieve or handle the stress that you find worked for you. Everybody handles stress differently. Find what works for you. Make sure that you take care of yourself both physically as well as emotionally. The better you feel, the better care you're ultimately going to provide for your patients. All right. We get a little deep in this, but I really wanted you to have a good understanding of what you're going to experience as a new critical care nurse. If you have any additional questions, make sure that you leave them down below. I love answering your questions. As always, follow me on my social media at Nurse Cheung on Instagram, or check me out on my blog at www.nursecheung.com, where there's a ton of additional information over there readily available to you in regards to the critical care transition in your career. As always, I will see you in the next video, and I hope that you're having a wonderful day. Bye.